Hi, good afternoon, everyone. I'm afraid to say it's just me here today, so you've just got to put up with me talking to myself. And we're going to talk about one of my favourite topics recently, actually, to talk about, which is mitral regurgitation. And I say it's my favourite topic because the more I learn about it, the harder I find it. We're going to keep things fairly simplistic as best I can, because I guess that's the way that I try and think. But the mitral valve is an incredibly complex structure, and assessing mitral regurg can be tricky. And what I really want to try and focus on as part of our work as critical care physicians is trying to recognize when it is significant and recognizing the hemodynamic effects of significant mitral valve regurgitation. Because obviously the hemodynamic profile that we're going to see with something like mitral regurgitation is one of almost a volume overloaded type pattern, where you've got a lot of blood that's going back into the left atrium and therefore not being able to be pumped out of the heart. And if you are fluid overloaded, it can make things worse. And we'll go through a few of the different sort of pathophysiology of mitral regurgitation. But that's what we'll focus on. And of course, it gets much more complex than this, and we're just going to focus on more severe end category. So the mitral valve is this horseshoe-shaped structure with the larger anterior leaflet is much bigger than the posterior leaflet. 3 scallops on each side, A1, A2, and A3, and on the other side, P1, P2, and P3, with an anterior mitral commissure and a posterior mitral commissure. And I know that this is the anterior one when I'm looking at it, because it's next to the left atrial appendage, and then you'd have the aortic valve up at the top, and you've got the tricuspid valve next door to it on the sort of posterior aspect. And one of the things I find really hard about the mitral valve is that we get lots of people talking about different things. And this view that I've got here, this sort of anatomical view, can be different from when we're talking about the surgeon's view, and it can be different when we're talking about the toe view. And that's why I'm going to try and let you know of a recent way that I've started to try and think about it, thanks to this guy that I'd like to big up at the bottom, is Dr. Ben Waldron. He's a cardiac anaesthetist at the Alfred Hospital. And if you get a chance to hear him talk about the mitral valve, I highly recommend it. And he's absolutely fantastic. And he really simplified it down for me. I'd like to steal a lot of his principles, pass them off as my own, as every good ICU specialist should do. And but of course, I'd like to say a big thank you to him for letting me use some of his slides, which are sourced off the internet, are freely available. But he has really simplified things in my mind. I'd like to try and do justice to that. But if you really want to hear an expert talk about it, I recommend you talk to Ben. Right, so we'll now go into the sort of schematic side of things, which is the way I find it is easiest to think about it. So here we've got a mitral valve, the larger anterior leaflet, the smaller posterior leaflet. 3 scallops, 1, 2, and 3. 1 is always anterior up here at the front, which is next door to the left atrial appendage, which would be up here. But we can just see the left circumflex coming off the left main coronary artery. Now you'll notice that the aortic valve is right next door to it, just as sort of the front edge of that anterior leaflet. You know, the aortic valve sits towards the front of the heart, and the mitral valve sits just behind it. And what I think is really elegant about some of this, and where I find doing echo, particularly toe, I can find really amazing for looking at the mitral valve, is how closely all of these are linked together through that fibrous skeleton. So the fibrous skeleton is really important, because if it gets dilated or it's abnormal, that's when we can start to see some of this sort of functional MR, and we'll come on to that in just a second. So the anterior commissure, anterior leaflet, posterior leaflet, posteromedial commissure, and this is the way I start thinking of the mitral valve when I'm looking at it. And the reason why I like this is because I get to hold up my hand, and I'll try and make sure I'm talking towards it. So I hold up my left hand, and when I look at my left hand, it looks just like I'm looking at the screen there. Okay? So I hold up my left hand, and I hold it in that kind of view, so that it looks as this does in this schematic diagram here. And we'll come on to why I do that in just a second. But all these schematic diagrams, they don't give away the whole story, do they? Because they're all in 2D. And the mitral valve is quite a complex structure. And as I'm sure you're aware, it's got this very unusual sort of, I think it looks like a crisp, it looks like a Pringle, doesn't it? Or a saddle. And that's where you can see that it's curved in both directions. so that you've got it's curved along both the long axis and the short axis, so it looks like a saddle. And that means that it can be quite hard to assess when you've got a two-dimensional imaging tool. And I guess that when we start thinking about some of the inadequacies of some of the ways that we're assessing mitral regurg, it is because we're looking at it in only one view, and it's a complex looking structure. And for things like PISA, PISA often assumes that you've got just a 180-degree line where the regurg is going through, the point that it's going through, and that point is a perfect circle. And as you can imagine, when we're looking at this, I imagine that the regurgitation is very rarely a perfect circle, and it's very rarely in a perfect sort of 180-degree plane. And if anything, normally it's in more like a sort of a 120 or 140-degree plane. So the next thing let's talk about, as well as the fibrous anatomy, is going to be the rest of the anatomy of the mitral valve. And so first of all, you've got your leaflet that we talked about, big anterior, smaller posterior, 3 scallops, and then you've got the chordae that are attaching to it. And what we're trying to get off this little schematic diagram we've got here is that the posteromedial papillary muscle and the anterolateral papillary muscle go to both the anterior and the posterior mitral valve leaflet. Okay, so that's a really important one to try and remember. And the posteromedial one is the one that's often got the single blood supply, so that it's often got a single blood supply either by the right coronary or more commonly, I think, the circumflex coronary artery. And the anterolateral has often got 2, the LAD and the circ. And that's why it's the posteromedial that can get ruptured with an acute myocardial infarction, more commonly the anterolateral. But either scallop can be affected, right? You can either you can have flails or prolapses affecting the anterior or the posterior mitral valve leaflet. And maybe we'll go through that when we start talking about myocardial infarction and complications thereof, and I'll just talk about prolapse in the case that we'll show a little bit later. So the chordae, they go to both chords, and they don't just go to the tips, actually. They go to the tips, they can go to the middle, and they can go to sort of closer to the annulus. And so these chordae are an incredibly beautiful, complex sort of web of cords trying to hold that leaflet together. And they are there to try and help prevent prolapse, so that when the mitral valve leaflet closes, you have quite a significant sort of period where those 2 folds come together. And that's how you get the sort of the meant to be sort of watertight area. And then can you imagine that if my hands are the mitral valve leaflet and you come together like that, that is quite a good way of providing sort of a watertight area. But as you start to maybe dilate, if you're getting something like functional MR that comes from either tethering or from dilatation, that area where they're coming together gets less and less and less. And so suddenly you're much more likely to get regurg if you've only got a little leaflet tip. So that's, again, one of the things we can look for on 2D is how much of a coaptation point we have. And if you've normally got sort of 3 to 4 millimeters, that's great, that's normal. And if you've got more like 1, you've got to be suspecting that we might get more significant regurgitation, particularly if we then fluid overload our patients like we've been known to in the ICU when we're trying to resuscitate them. And that's when you can start making regurgitation go worse. And the more regurgitation you get, the more likely you'll get into that vicious circle. So that's one of the first key clinical points. If it's significant regurgitation, you've got to pick up, you've got to dry them out, because if you don't, regurgitation makes things get worse and worse and worse and worse. All right. So these are the sort of different views that I'm talking about. You know, we've got, these are all the mitral valve, obviously, but one's the anatomical view, which is the way that I think about it and the way I showed you in that schematic. But you've also got other ones that in other textbooks I find that they can show you the, you know, maybe the short axis view that you get from a toe, which looks more like the middle one. And then the last one, they talk about the surgeon's view when it's all on its side. They're all the same thing, but I recommend just trying to learn one and learn that well. And the one that I like is the anatomical view. And I like the anatomical view because I've got a left hand. And if I hold my left hand down in front of me, it looks a lot like the anatomical view. And then I know that if I just look straight, if I then hold my right hand and I just point it flat at my left hand, that's 0 degrees. That's an apical 4-chamber view, right across there. And that depends then on where I then fan up or fan down. But if I'm straight across there, I'll be approximately across A2, P2. If I pull my toe probe up or I fan up into my transthoracic, I can get A1, P1. If I come down, I can get towards P3 and A3. And the good thing with my right hand is if I hold it there like that, I've got my hand in front of me from the mitral valve like that. If I twist it, the toe probe goes around in a clockwise fashion with my right hand, and then straight up and down becomes 90 degrees on the commissural view. The commissural view, 60 gives a 2-chamber. And that means that I know I can hit sometimes P1, A2, P3. But if I look left or right, I can get more of the P1, A2, or if I go the other way, I can get A3, P3. And what's interesting, maybe if we're sitting in that commissural view, why you often don't see that Pisa, is because, this ties in what we were saying in that last slide, is because then I'm right down that sort of A1, P1, or the straight part down here. So often you don't see a Pisa because you've got a big line rather than a hole. Fascinating, huh? And then rotating around to 120 degrees, you'll see that the aortic valve normally sits up at the top at the front of the A2, like I said, and that's how we go through that sort of 120 or 3-chamber view, 120 degrees on toe, or your parasternal long axis or 3-chamber view with transthoracic echo. Okay, so it's maybe a bit hard to try and explain talking into a camera by myself in a room, but I hope you get the idea. So holding your left hand out in front of you, you get your anatomical view, the left one. Straight at it like that is where you get A2, P2, that's 0 degrees on toe, or the apical 4-chamber view. You can rotate round, rotate around 90 degrees, and we get our sort of P1, A2, P3 area. And then come around to 120, and we go at A2, P2 again with our aortic valve at the top. But the problem is that in all the textbooks, like in the guidelines about toe, this is what they show. And as I said, I look at that and I'm like, oh, everything's back to front. So I just switch it around. And that's the way I think about it. So I just flip it in my head, and here at 0 degrees, you can see that straight across. I'm holding it in my hand, and A2 and P2. And forgive me, it's now a mirror image. And you come to 0 degrees, and we come up through sort of A1, A2, P3. Can sometimes get the P1 in there, depending on which way you're looking across. And that's why you get P1, A2, P3, with maybe your commissural view or 2-chamber view. And then 120, or they go to 135 here. You're coming through your aortic valve, that's your 3-chamber view, and you're classically at A2. Okay? So just worth practicing, thinking about, use your hands, left hand, anatomical view, right hand, toe probe, keep it flat, that's your 0 degrees, apical 4-chamber view. And I've got to thank Ben Waldron for helping me out with some of that. I stole some of those ideas by using a hand off Twitter, and the rest of them off Ben Waldron, and I don't know, it's just, been learning this for a long time, and I've certainly found that the most easiest to remember, because it's probably taken me 7 or 8 years to try and get my head around that. Okay, so let's talk about mitral regurg a bit further now. Now we've got the mitral valve complexity and the anatomy out of the way. So when we're looking at a 2-chamber view, so when we're looking at when we're looking in our B mode, when we're looking at our our movie, this is where we start to have to look with our 2D exactly what's going on here. So you can see here that I've got a left ventricle that's not working well. It looks dilated, and I don't have a lot of coaptation. And that's got to tell me straight away that that looks like it's probably going to be significant mitral regurgitation in there. I know I've got raised left atrial pressure because I can see a large left atrium and it's bulging over to the right atrium. So I'm not surprised when I stick my color Doppler on it, I see quite significant regurgitation. Anything that looks like this, which I think is significant, means that we need to do some form of quantification, or going to look if there's any further hemodynamic effects such as systolic flow reversal in the pulmonary veins, because you can get color Doppler wrong very quickly. So therefore, in terms of assessment, I've got to start with my 2D assessment, then I'm going to go to my color Doppler. In terms of the etiology that we've got, we know that we can get problems with the annulus and the fibrous skeleton in terms of dilation. We can get problems with the actual leaflets themselves, which can prolapse, where prolapse is the valve still points towards the left ventricle, but goes past the annular line. I'll show you a picture more in a second. Flail is where something is broken off, and actually the leaflet points down towards the left atrium. You can have that can be because of chordae rupture or papillary muscle rupture. and that can happen because of things like ischemia, surgeons, calcification, things like that. And the last one we can talk about is functional MR, which can happen with things like cardiomyopathies, regional wall motion abnormalities, and the like. I don't think any talk's probably not any talk about mitral valve. You've got to obviously mention this incredible legend. I think he's a cardiothoracic surgeon. I can't remember where he's from, but he thought this up when he was a young man, I understand, and it's been a wonderful way that we've described it. I don't think it's universally used. I think there are other ways of doing it, but you'll have an idea. And I think you've got to know that the Carpentier classification goes through mitral regurgitation. In terms of type 1, where we get annular dilation with normal leaflet motion. Type 2 is where you've got excessive leaflet motion from things like prolapsed flail. Then you've got type 3A, restricted motion, rheumatic fever. And again, you remember that from a mitral stenosis talk, that in a majority of those cases, they've also got some form of mitral regurgitation. And then the last one is just restricted motion in systole, which will come things, which is where the functional MR comes from, the things like ischemia, where you get that papillary muscle gets locked and can't move. So you sort of, instead of that being normal, you get something that goes like that. So you get horrible eccentric MR. Mitral valve regurgitation is a really good one to try and do with interpretive dance. I don't think I can do a talk without doing the interpretive dance. So a bit of an idiot doing by myself in the room. Right, so let's have a look at this one. What do we think is the severity of the regurgitation is going to be? I think we'd look and say it's going to be significant, right? You've only got a tiny little coaptation point. We've got a big left atrium there. Look like you've got a dilated left ventricle. We expect there to be significant mitral regurgitation. It looks like almost like a volume overloaded left ventricle that's not working well. And if this is all due to MR, we're at the bad end of the scale. Okay, so it's hard to pull these people back. We can see the left atrial dilation, the intratracheal septum bowed over to the left, the diastolic expansion of the volume overload, and the annulus that looks dilated. That should be normal is 2 to 3 centimeters. Okay, so let's stick some color on it. Different patient, obviously. And I guess what I'm trying to show here is the problems that we've got with color Doppler. So you'll have that sort of you'll have the idea of severe being if we've got greater than 60% of the left atrium being filled with color Doppler. I think it's probably one that we've all heard before, and the less big the color Doppler, the less severe the mitral regurg. And these are the same patient. I've got these images on, one with the gain turned down, one with the gain turned up. And I'm trying to show the problems with color Doppler in that your settings are really, really important. So you've got to make sure that your gain is correct, not over, not under. So I think you find out where you've got, so you can see at the bottom, I've got some speckles coming through the rest of the image, and that probably means it's too high. You turn it up so you've got the speckles, and then you turn it back till you lose the speckles outside of the area. The next thing is going to make sure your scale's right. And for things like mitral regurgitation, I classically have my scale up around about 70 centimeters, 70 centimeters, 65 to 75 centimeters per second, because that's, we're dealing with sort of higher end scales. If we're looking at slow moving structures like patent frame and ovales, you have it close to 25 or 30. We can try and have a look at our vena contracta. The vena contracta is if you look at the bottom, it's just from where the hole is. It's the smallest distance as that jet comes through that mitral regurg, and we can measure that there. Finally, Pisa's probably one of the more common ways it's used is in mitral regurg. You must have a relatively central jet to make this reliable. You've got to have good imaging, zoom in on it, and the settings have to be right. And I think we go through it a little bit if we've got time. It's fraught with many limitations. It's not something I do routinely in the critically ill or in standard patients, to be honest, because it's so easy to make mistakes. So I've got to be honest, I think we've got other ways of trying to assess it significantly. But it's probably not a universal whole view, right? Just because I don't do a lot of, I guess we don't do a lot of Pisa because it's fraught with hemodynamic instability and problems in the Okay, so let's ask quick questions. So what do we think about the etiology of the mitral regurg in this patient? So we'll look at our 2D picture, and I think we see that we don't have that normal coaptation going on. It looks like there's some form of discongruity between those two leaflets. And I still think that that So we've got the anterior mitral valve leaflet at the front here next door to the septum, and then we've got the posterior mitral valve leaflet is the other one. I know the one next door to the septum is the one that's closest to the aortic valve. The aortic valve's at the anterior section, so that's how I know that that's the anterior valve. But I've still got the posterior mitral valve leaflet tip that's sort of pointing towards the left ventricle. It's not pointing down to the left atrium yet, so that means it's a prolapse. So now, having looked at that, I can then look at the color. And with the prolapse, remember I said it sort of goes like that, which means that the regurgitation goes in the opposite way. That's exactly what it looks like on a color Doppler. Lots of green there, lots of variance, lots of chaotic blood flow, and it's going away from the prolapse. So it always goes away from the prolapse or away from the flail. So I think we've got prolapse of the posterior leaflet there. So it doesn't look restricted, it looks excessive in motion. It's got good openings, so there's no stenosis that's going on there. The anterior one looks fine, a bit thick, but fine. So it's number 4, prolapse of the posterior mitral valve leaflet, and there's no SAM, there's no systolic anterior motion of the anterior mitral valve. Okay, so that's what it looks like in an anatomical view. This is the posterior valve that you can see. It's got excessive motion bowed up like this in the anatomical view. And there's just little cartoons that I drew for a textbook for a friend that A is normal. Or maybe you can say, maybe I actually messed that up a little bit and say normal is where you've got about 3 to 5 millimeters coaptation. This is almost getting towards the functional MR, which I'm trying to sort of show, and B there when you're actually pulling it aside and the leaflets don't quite coapt, so you get that nasty regurgitation going back from annular dilatation. C is when we've got ischemic, so again it's the kind of functional MR where you get restricted motion of a valve leaflet, and that means that the regurgitation goes towards the lesion in restricted motion functional MR. D and E are flail for D, prolapse for E. Flail, D, because it's pointing down, the leaflet tip is pointing down towards the left atrium. E, the leaflet tip is still pointing up towards the left ventricle. Classically, it goes past the annular, so I can probably draw this cartoon a little better, and maybe that should be more of a bit of a U shape actually going past that annulus. And that's more the classic of a prolapse. So maybe those cartoons could be done better in retrospect. Okay, as we discussed, color flow is going to depend on your gain settings, your pulse repetition frequency, the depth, so you need to have that box as small as possible to help with your resolution, the direction that the jet is. So the idea of, remember that Coanda effect is a really important term to mention in eccentric mitral regurgitation. Because if you've got severe mitral regurg, it can fill 60% of the left atrium if you've got adequate settings and it's central in origin. If it's eccentric, the Coanda effect is that effect that helps planes take off, and that's because one side of the plane's wing is got a greater diameter than the greater sort of curve than the other, which means as air goes over it, it creates lift. Because as the air goes over that leaflet wing, it forms some sort of grip to that side. You get some form of the power, so kinetic energy of that air moving passes over with the turbulence and actually causes some sort of friction, I guess, and some adherence to the surface that it's traveling over. And it's the same with liquid. And if you've got it less on one side and more on the other, that creates lift, and that's how planes take off. I think I've got that right. I'm obviously not an engineer. But the Coanda effect is what we call, so that kinetic energy means that some of the chaotic flow that we see in color Doppler for mitral regurg is actually transmitted to a force sticking it against a side of the left atrium. So that makes the color Doppler look less severe and eccentric. So you can underestimate the severity of mitral regurgitation on color Doppler if the regurgitation is eccentric. Last thing to say about color flow, and with many of the other parameters for mitral regurg, is that they are load dependent. So that if you have someone who's fluid overloaded, you can overestimate the severity of the MR when they're at a standard euvolemic resting state. So the jet size, it depends on the kinetic energy, central versus eccentric. The systolic function, the more severe or the more hyperactive a ventricle is, the more blood flow you're going to get coming back, the more it can make mitral regurg look significant. Depends on your left atrial pressure, you've got to have a pressure difference for blood to flow into a structure. And so If you've got raised left atrial pressure, the MR can maybe be underestimated, and the direction of the jet, as we said, central, the colored flow can look greater than if it's eccentric because of the coanda. So the jet area is more than 40% of severe. They can talk about 60% sometimes in other guidelines. The eccentric flow jet appears smaller than a free jet, coanda effect. MR reaching the posterior wall, usually severe, and that is very dependent on your setting. Okay, the vena contracta we talked a little bit about. I'm sorry I didn't say too much about it, but it is a useful parameter to do. So it's that short distance between the anatomical orifice. So if you've got a mitral regurgitation hole there, the jet will come in together, and it's that narrowest portion. You've got to zoom in on it. You've got to get your settings right. You've got to scroll through it, zoom in on the section that you're after so you get the best temporal resolution, and you can measure it there. And sort of greater than 6-7 millimeters is severe. Less influenced by loading and hemodynamic factors than the other ones, so it is worth doing if you're not sure. But try and use, this is really important. So this is when I was trying to get to, talking about PISA the first time, I'm talking about your mitral valve in your commissural view. You don't get that PISA or a nice vena contracta when you're right the way down in between sort of A1 and between A1 and P1. You're down to that vertical section of that mitral regurg, and you often don't get the vena contracta or PISA nicely. And that's why you've got to use those orthogonal views. You've got to use the four-chamber view or the long axis view when you're actually sort of cutting across the mitral valve leaflet tips, not in line with it. Okay, and just still coming to the end of things here before we get to do a real quick case. The pulse wave and continuous Doppler. So this stuff is gold for trying to pick up whether something is significant or not. And there are a few little tips and tricks that I just wanted to stick in here. So the first one, let's talk about color, the continuous wave Doppler. So I use my color Doppler to try and guide. I'm sorry if it's a little small, but you get the idea. For mitral regurgitation here in this view, I'd use the color Doppler to tell me where the jet is going, and then I'll try and get myself in line with my continuous wave Doppler cursor to try and make sure I'm parallel with it so that I'm lining up with the mitral regurgitation as best I can. The signs of something being significant with mitral regurg, as you can see I've written down here, is if you've got a very dense signal, a very dense filled-in signal like this one. It suggests there's a lot of blood flow going backwards. And so below the line is flow away from the probe, so that's the mitral regurgitation in this four-chamber view. Nice and dense, well demarcated, full parabolic flow. And that's mitral regurgitation. We'll see here that the normally mitral regurg, if you've got normal cardiac output and normal cardiac function, should be easily greater than 4 meters a second. So this one here straight away was suggesting we've got some reduced cardiac output. There's a significant MR, and there's a reduced systolic function of that left ventricle. One of the next signs, if it's asymmetrical, if it's not that parabolic, if you've got this triangular shape with cutoff, particularly if the cutoff fits, if it gets back to the baseline before the end of diastole, so before the end of the T wave, that's associated with rapid equalization of pressures. That's significantly raised left atrial pressure, and that again, the triangular or asymmetrical MR shape in continuous wave Doppler. All right, and then we're going to bring you on to my favorite ones, which are using pulse wave Doppler for severity of MR. So the reason why I like these is that there's less ambiguity with them. You can't mess it up too much. The first one at the top here, this is pulse wave Doppler through the mitral valve inflow view, all right? And what we're going to see here is about the E wave velocity. So normal E wave velocities, if you don't have any mitral stenosis, and you sort of got normal flows going through, normal E wave velocities are less than 1.2. When you start to get greater than 1.3, that suggests that you've got a lot of blood coming back into the left ventricle. So that's either you're horrifically fluid overloaded in a hyperdynamic state, or you're dealing with severe MR. So you've got a whole bunch of blood that's coming back in the left atrium, and you've got a lot of blood coming forward into the left ventricle. So greater than E wave velocity greater than 1.3 meters per second suggests significant mitral regurgitation. And that's as long as your ejection fraction is pretty close to normal, so greater than 40%. Okay? So nice little tip and trick, commonly missed. And then the last one is a little bit harder to image, and if you're not doing it, I highly recommend that you start having a crack at it, because it's not rocket science, but you can't get it in every patient. And you certainly can get it in the critically ill, and it's really useful if you can, easy with tone. So it's in the pulmonary veins. I really like looking at this because what we've got here is me imaging the pulmonary veins in your apical 4-chamber view. Normally, I put the pearl I've got for that is that you put your color wave box over your pulmonary vein. So that's at the back of your, so you've got to increase up your depth, stick it at the back. And I turn down the scale. So I go down to closer to sort of 30 centimeters per second. I'm looking for low flow states. So here you can see my low flow states are around about sort of the 20 to 60 centimeter mark. So if I have my color Doppler at about 30 centimeters a second, you can pick up low flows better. And often, even though you can't see it, you can still, even though you can't see it, you can often see flows in that vein somewhat, which means that you can put your pulse wave Doppler over it and just try and get a flow pattern that comes through that looks something like a pulmonary vein. Now, what normally happens is you get an S wave, which is doing systole, coming towards the probe. So it'd be from systole, from the beginning of the QRS to the end of the T wave. You have a systolic flow normally, followed by diastolic flow, followed by a little A wave reversal. When the atrium contracts, it pushes blood away from the probe, so back into the pulmonary veins, and that's obviously below the line. But here what we can see is we've got significant systolic blunting, if not systolic flow reversal. So we've got no S wave that's there. I think we've actually got S wave that's going backwards, just a systolic flow reversal, and a big D wave. And that is suggestive of severe mitral regurgitation if you've got systolic flow reversal. You can do calculations. These are not recommended in the guidelines too much anymore. And I suggest using the other ones that I've mentioned. You can do it same way as you can for things like aortic regurgitation and the like. And you can compare one flow to the next. But if you've got significant mitral regurgitation, sometimes this is, this would not be indicated. So this is what I do. This is Cheat's method. Just compare your LVOT VTI with your mitral valve VTI. And if it's greater than 1, that might suggest significant regurgitation. Not perfect, but it's a way, again, a nice easy way. As long as you don't have significant aortic regurg, you can just compare one with the other. All right, and if you've got a hell of a lot more blood going through the mitral valve compared to the LVOT, obviously that's suggesting a whole bunch is going back towards the left atrium, which is the mitral regurg. Okay, so these are the criteria that are suggesting severe MR. So 2D evidence of the apparatus is not quite right, or you don't have a decent coaptation point. An estimated regurg orifice area of 0.4, but again, I don't do a lot of quantification on that. That's the same with the MR volume and the MR fraction. Vena contractors greater than 7. The mitral regurg color Doppler reaching the posterior wall, or a jet size greater than 40, actually 60 of the left atrial size. And dense, continuous wave signal, which with the parabolic flow, and particularly then if it becomes asymmetrical, particularly with the cutoff sign. Nice ones here, which is the pulmonary vein having that systolic blunting, the systolic blunting in the pulmonary vein flow, or systolic flow reversal, which is associated with severe MR. And the last is the pulmonary hypertension, because of the flow going from raised left atrial pressure through the lungs back to the side of the heart. Okay. So I guess in conclusion for that little talk, we've got, excuse me, sneeze. The mitral valve pathology is really common, particularly in the critically ill, and MR would be one of the more common, more and more common valve abnormalities. Assessments have got a systematic 2D, color Doppler, pulse wave Doppler, and continuous wave Doppler, and try and use all modalities available. So you're looking not just at your color or continuous wave Doppler, use your pulse wave Doppler, looking for that E wave on the mitral inflow greater than 1.3, as well as looking back to the pulmonary veins to consider systolic blunting or systolic flow reversal. And a lot of cardiologists would say that you need to know blood pressures if you're going to assess these. You need to know what the hemodynamics are and the critically ill, how much cardiovascular support they're on, and what their volume status is like. And you must put that into clinical context. And that's why I often say, if we've got some significant mitral regurg, then we need to reassess this patient once they're hopefully clinically improved and consider diuresis if they're significant at all. Okay, so that's it. Sorry, I think that we've finished off the so much of the thing. We are going to record this though, so we can put it out. Why don't we go through a case, and we'll quickly just spend 15 minutes just looking through a case that I did, and some of this is not great. We'll particularly talk about the leaflets. So, tell us about this one, Hatim.
Okay, so this personal long axis view showing normal LV function. Probably the left atrium will be on the dilated side. Aortic root looks normal grossly, and the mitral valve, there is posterior valve leaflet, there is a prolapse.
Very nice. And how do you know that it's a posterior mitral valve leaflet? Do you have a tip and trick of doing it?
So it's the one that's attached to the posterior wall.
Yeah, nice. Yeah, fair enough. That's a pretty silly question. I always remember just always saying that the anterior mitral valve leaflet is the one next door to the septal, next to the aortic valve, because the aortic valve is anterior, so it's always that one at the anterior. So it's got to be the posterior. How do you tell the difference between a prolapse and a flail?
So it depends on the whole segment. So whether the whole leaflet is having the cusp shape, like concave shape during the systole, or it's just the tip.
Nice. Nice. So I read that if they've got the end of the leaflet pointing towards the left ventricle, prolapse, and pointing towards the left atrium, it's flail.
Yeah. So this. So this color Doppler across both the mitral and part of the LVOT, and the main concentration here is on the mitral valve, and showing. I can't really comment on the severity, but it looks moderate to severe, at least mitral regurg.
Yeah, nice. And we were talking about some of the problems with color Doppler. So tell me what some of the problems are with the color Doppler, and you're also able to be rude about my images because I really messed this one up, which is why I left it.
Yep. So probably the scale is on the low side, so needs to adjust the proper scale.
The scale up here.
Yep. 6.3.
Yeah. What about that one?
So that is a little bit over as well. So
yeah, but they're different, right? They're normally the same, right?
They should be.
Yeah. So what's happened here? Why is it like this?
I think probably part of the setting.
Yeah. And why have I done that? So I've moved the baseline basically. Moved the baseline up to close to 0.4.
Yes. And
I do that because on the image before this, I was trying to do a PISA.
Oh, okay. Yep.
And with the PISA, you need to have the flow of 0.4. Means that if you've got a PISA signal, which is where the Nyquist limit is reached, if it's greater than a centimeter, that suggests that you've got the regurg volume greater than 60 mils.
Yep.
And again, I'm sort of trying to be clever, and then I've gone on and taken more pictures, and I've forgotten to change the scale. So this is one of the problems I think with PISA as well, is you get all trying to be clever, and you can then get caught up a little bit. And particularly, I think with things like flail, remember PISA normally assumes you've got a 180-degree perfect area, and obviously if you've got prolapse, you've got anything but a 180-degree, and it's part of the reason why I don't like it very much, because it's really hard to do and I mess it up always. Nice. So which direction would you expect the regurgitation to be in this next view? So here's an apical four-chamber view. We can see our anterior leaflet, which looks a little bit thickened, but normal orientation. Then our posterior leaflet, which is prolapsing into the left atrium.
So it would be eccentric,
yep.
And it would be directed more towards the left lower pulmonary vein.
So left lower pulmonary vein. So you think it would be going over in that direction?
Sorry, no. It would be this direction. It would be going here.
Interesting, because I think that leaflet, if that leaflet is coming across like that, you're going to get a hole that's going to be there, and I think it's going to go in that direction. Which is why we see it like that. Okay. So in both prolapse and in flail, it goes away from the lesion.
I'm just confirming severe.
Yeah, and why are you saying severe on this?
So it's reaching the
Scale's better, isn't it? That's right.
Yeah, scale is better, and it's occupying the whole left atrium, and even reaching the pulmonary vein.
And reaching at the back of the wall, which is suggesting it can be significant. It's important to note that the left ventricle is
contracting well. Yep.
And again, we can probably bag up my picture. I should not have that
Big
color
sector.
box filling the entire screen. That's not appropriate. So this is me trying to take a picture, I think, of the mitral valve inflow view, and that's just rubbish. So I'll just quickly show about what I'm talking about PESA. So often you move the baseline in the direction that the regurg is going. So here I've moved it down to a 0.4, and I can't pause it brilliantly. So I then try and find mid-systole. And yeah, I'm not doing a great job. And we're looking, for a Nyquist limit. So that's where it goes from sort of yellow back to blue. Oops. Yeah, we're looking for the Nyquist limit where it goes from yellow to blue, and you measure that down then to the hole where it's going through. And if that's greater than a centimeter, and you've got your scale down to about close to 0.4, it suggests severe. And I can't do it justice, can't persuade you. That looks like quite a big PESA jet. It's suggesting that we've got severe regurgitation because it's greater than 1. So I tried to do
Would you do vena contracta on that as well?
Absolutely, you could do a vena contracta on that, but I think with both of them, I should be zooming in.
Yes.
So that what I'm interested in is filling the screen, and we get the best temporal resolution. So I think I want to truly pause that up. Okay, so what would you like to do next?
Toe.
Nice, absolutely. Don't forget that in the exam. The answer is always what ladies and gentlemen. I'd like to do a toe. They show a transthoracic. Fantastic. So we've got a normal LV size.
Normal LV size function.
Yeah, very nice. Looks a little bit thickened, which might consist of someone who's got some form of significant MR, who's having to deal with a precious volume overloaded system. Blah, 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 blah. Right.
Okay.
So which leaflet is which?
So this again, the posterior leaflet.
Yep.
This the anterior.
The posterior, anterior.
Yep.
And which leaflet cusps are those? Which scallops are those, if you had to call them? And you missed the first part of the talk when I was telling you how to do it.
I'm not sure.
So again, we'll just recap quickly. So the good news is we've got 2 hands, so we can take our left hand, okay, and we hold it up so that our
I remember now.
And
so this would be the P2.
Yes,
and probably an A1.
Yeah, and it depends where we're at. So again, it says A1, A2, A3, P1, P2, P3. So if we're across there, often we're about the A2, P2 area.
Yep.
But we don't know whether, if we look up a little bit, we could be more to the A1, and if we were looking more down. It sort of depends where we've got the toe probe.
Yep.
But we're definitely doing the anterior and posterior, and it's probably A2 and P2. Nice. Which direction do you expect the regurg to go?
So regurg now will be going this direction. To be here.
No, again, remember, look where the prolapse is happening. You're just going anteriorly, because we've got the hole that's there. As it comes up like that,
the hole will be,
it goes in that direction. Yep. Beautiful. So good guess. We've got that beautiful PESA that you can see in there, which is not small, and we've got this eccentric looking MR.
So now you don't need to adjust the color scale.
If we were going to do PESA, we can still see PESA because it's so bloody awful. We can still see it even though we haven't changed the setting. Okay. If we wanted to measure it, just the cheats method is when you move the scale close to 0.4, then you just say if it's bigger than a centimeter, you say it's severe. Okay. But again, the problems with it are that it's bloody difficult to do, and we're assuming that 180 degrees, we're meant to zoom in on it, making small measurement errors can make a big difference.
Yep.
So you said that on the last one, you said it was severe MR because the color was filling the left atrium. But the color isn't filling the left atrium here, so it's miles, right?
No, the point that again, this is not aligned properly with the.
I guess talking more about the color area. So on the color Doppler, you said if it fills the left atrium, it's significant.
Yeah, I think MR. Probably
so
we need to adjust the angle so we can fan through the.
And let's say I've done that, and this is perfect. This is the best image that you can get. And I'm also being a bit facetious here, but if we said that severe MR is associated with the color Doppler filling the left atrium, Why is this severe MR not filling the left atrium?
I'm not sure.
What's the magic number what's the magic word when we get an eccentric looking jet?
Yes,
that one.
No,
it's the Coanda effect.
Yes.
Because that's the one that makes planes lift off of the ground, so that when we've got an eccentric looking jet, some of that kinetic energy is transferred to another kind of energy that sticks it to the wall, which means that you don't get a lot of the other chaotic motion that comes in. Okay. So there's me trying to show you how to do it. So I've got a piezo radius of 1.1, suggesting that we've got at least significant MR. Blah, blah, blah. If we're in a sinus rhythm, which I can't quite tell if this is me trying to show that if you've got a pulse wave coming through the leaflet tips, it's greater than 1.2.
Yep.
Because I've got it 1.3, excuse me, no significant blood flow. Or maybe we'll say So what leaflets are these? And I know I kind of found through it at some stage.
So from this direction, it would be P1.
Nice.
Yep. And P1 would be taking the A2, A3.
Yeah, nice. So,
yep.
So you can have P1. I think at some stage here, we're just going straight through. When you can't see any holes and you've got the big ballooning bit, that's going to be the P2 flail probably.
Yep.
Because we know it's the posterior leaflet that's flailed, not the anterior. And that's why we know that we're probably looking at P2, P1 there. And when we're across, again, I'm so sorry, I can't scroll through these very well. But when we're here, that's the posterior leaflet. And when we come to there, I think that's anterior. So I think that's me fanning through it. So it's, again, not great imaging fanning through your kids. So here at about 77, we're probably like that. And I think we're probably looking at P1, A2, P3. And no flail going in there, because it's probably the P2 that is flail. 106 degrees. We're probably looking at P1, and here's A2, and here's A3 or P3 probably there. Yeah, does that make sense? Yep, around like that, or P3 like that. 130 degrees. Which scallops are these?
So this the P2 still.
Yes.
Yep. And probably would be with A1.
I think A2.
A2.
So 130 degrees is across like that.
Yes.
Very nice. Blah, 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 blah. Very nice, very nice, very nice. Okay, so this would be the last thing I think I want to show you. What's
so this is the pulmonary vein. This would be the left upper.
Yeah, I think probably 50 degrees might be the left lower.
Left lower.
Yeah, left lower pulmonary vein.
Yep. And it's so there is reversal of the flow across.
Beautiful. During which period?
During the diastole.
Or the other one, because again, it's from the beginning of the QRS to the end of the T wave, the systole.
So during the systole.
Yes, it's systolic flow
reversal.
Because this is the D wave, this is the S wave. This should be much bigger.
Yes.
In which case we're dealing with systolic flow reversal, which is suggesting
of severity.
I think that's probably about it that I wanted to talk about. You can see how big that piezo is. Big left atrium pushing over to one side, and we've even indeed got our left to right shunt through a PFO because you've got such raised gradients, which is why a patient can be hypoxic. Beautiful. Well, why don't we leave it at that? I think that's probably all that I've got for this case. Hope that was useful. Say thanks very much, everyone. I hope you enjoyed it. Thank you.